Hello, everyone, and welcome to the Academy for Eating Disorders webinar entitled Parent-Based Prevention, Empowering and Guiding Parents with Eating Disorders with Shiri Sharvit. My name is Sarah Forsberg, and I'll be your moderator today. Also with us is Ronald Fan, AD's Membership Manager. If you have any questions or concerns about this webinar, please feel free to reach out to Don Gannon at AED headquarters via email at dgannon@aedweb.org. Just a couple of housekeeping items before we get started. All participants are muted with the exception of the speaker and myself. The webinar is scheduled for 60 minutes and is being recorded. It will be posted on the AED website shortly thereafter for AED members to download at their convenience 24 hours a day, 7 days a week. In just a few minutes, Dr. Sharvit will begin her presentation, after which she will answer questions from the audience. Please feel free to submit your questions to the speaker during the presentation using the Q&A text box on the bottom middle of your screen. And I'll read them to the rest of the group when the question portion of the webinar begins. Dr. Sharvit, let's check your volume quickly. Please just say a few words, and if a couple of the participants can let me know if you can hear them clearly by sending a message in the Q&A text box I just mentioned, we will get started. Shiri?
Hi, everyone. Can you hear me well?
I can hear you. Can everyone else hear Shiri? And it looks like a yes. All right. So with that, thank you everyone for letting us know the volume is good. And I will go ahead and introduce our speaker. Dr. Sharvit, PhD, is Associate Director for Training at Palo Alto University Center for M2 Health, California. She's previously worked at Stanford University Eating Disorders Research Program for 4 years. Dr. Sharvit's clinical and research interests include eating disorders from infancy throughout the life cycle, family-based interventions incorporating technology and mental health care, and clinical training. Her book, co-authored with James Locke, MD, PhD, Parents with Eating Disorders, A Treatment Guide, was recently published by Routledge Press. And with that, I'll turn it over to Dr. Sharvit.
Thank you, Dr. Forsberg, for this introduction. Before I delve into the presentation, I would like to present to our audience the moderator who facilitates this webinar. Sarah Forsberg, PsyD, is an associate clinical professor at the University of California, San Francisco, Eating Disorders Program. Dr. Forsberg received her doctoral training at the PGSP Stanford Consortium. She later completed her pre-doctoral internship at the University of North Carolina School of Medicine and her postdoc training at Stanford University Eating Disorders Research Program. Dr. Forsberg's work focuses on the development, dissemination, and implementation of novel treatments for childhood eating disorders, with a specific focus on family-based treatment. She's an expert in integrating research into clinical work and supervision. The book, Family-Based Treatment for Restrictive Eating Disorders, A Guide for Supervision and Advanced Clinical Practice by Dr. Forsberg, Locke, and Lagrange, was recently published by Routledge. Thank you so much, Dr. Forsberg, for finding the time in your busy clinic and private practice schedule to take part in this webinar.
Of course, it's my pleasure.
Okay, hi everyone, and thank you so much for joining us today. Being a parent is both one of the greatest pleasures an individual can experience and both a significant stressor, as some of you may experience yourself. Although the birth of a child often inspires feelings of love and closeness between the new parents, couples also report increased conflict and feelings of inefficacy. Such experiences may be due to biological, psychological, and interpersonal changes that accompany the transition to parenthood. These changes may serve as catalysts for individual and family growth or lead to a maladaptive interactional style within the family, with broad consequences for both parents, their relationship, and the development of their child. In the context of eating disorders, these biopsychosocial changes may facilitate recovery in some parents while increasing or creating symptoms in others. Therefore, parents with personal histories of eating disorders may face unique challenges in their roles as parents and partners. I would like to make an overarching statement before we begin. Some of you may feel that what we will discuss today would feel a bit somber, but I'm quite happy, frankly, that we're having this conversation. The fact that our field is gaining more knowledge in how to support parents with eating disorder, this is a very optimistic sign to me, and I hope that you will share my optimism by the end of this presentation. Before I explain a bit about parents with eating disorders, let's hear some quotes from parents themselves. A mom of a child who's 3 years old says about him, for me, a fat child is the scariest thing in the world. I'm scared to death he will be fat, especially as a child. I know what it's like to be a fat child, and that is one of the most horrible experiences a kid could have. While I will not personally myself would use the term fat child because I use person first language that is respectful, I wanted to share this quote, although the language is a bit harsh, to express what this mother feels and how she perceives her child and what scares her most about him. Another mother says, also about a boy, he enjoys food. You see a child who takes pleasure in every bite, and it simply tortures me. With my other children who eat the minimum they need, I sympathize much more. He eats, and I immediately translate each of his bites into tiny fat molecules, into him not being popular and never having a girlfriend. Again, you can see you can feel the concern and the stress that these parents are feeling. It's clear that they want only the best for their child, and if they live in a society that promotes thinness and food restriction, it's very hard to see that your child deviates from the norm, so to speak. Another parent says about dinner time. The one thing that really annoys me is when my partner asks what we are having for dinner. You know, this is my biggest problem. As far as I'm concerned, it is perfectly fine not to eat anything. So don't ask me what we'll eat. And then we become very stressed in the last minute because time passes, no one prepares anything, and there's no food for the kids. We just avoid preparing food for a family dinner. Again, this parent shared their experience very painfully, and it was clear that it's a hard thing for them. And finally, a mother who has children of both sexes, and she talks about her toddler girl. I honestly don't know if I were to choose for my girl to be fat or have an eating disorder. I don't know what I would prefer. I feel very bad for even thinking this. When I feed them both, her son and daughter, I give him a much larger portion than the one she receives. Him, I feed when he doesn't eat well, and with her, I insist that no one else feeds her. And the minute she doesn't want the food anymore, we take away her plate. Okay, so let's talk a bit about what's going on here. There are decades of developmental psychiatry literature that inform us that the formative years are important for fostering normal and healthy development. And the influence of parental eating disorder on children is likely a result, as I mentioned before, of a complex interplay between a number of factors, including environmental and genetic factors. The heritability of anorexia nervosa, bulimia nervosa, and binge eating disorder approximates 40 to 50%. And relatives of individuals with anorexia nervosa are 11 times more likely to have an eating disorder themselves. What may be going on here? I think that the term of genetics and epigenetics could be very helpful in understanding what's part of the underlying processes. Epigenetics is a relatively new field focusing on how the processes of gene function and the regulation change without a change in the DNA coding sequence. When DNA methylation occurs, it means that there are some genes that are switched off, so to speak. And there is a hypothesis that lower DNA methylation in the offspring of mothers with eating disorders are not turned off, which means that some genetic sensitivities get to be expressed, for instance, for anxiety, for depression, and also for appetite regulation and emotion regulation problems. This means that parental eating disorders may leave epigenetic marks that impact upon offspring development, and this may be even intensified when there is a history of restrictive eating. Okay, so beyond the genetics and epigenetic sensitivities that may be overly expressed in a society that promotes thinness, there could be other pieces in the puzzle. And here I would like to outline them. Mothers with eating disorder histories report more pregnancy-related complications, including greater nausea and vomiting, poor nutrition, greater weight gain during the pregnancy in comparison to mothers with no eating disorders. Additionally, they need to cope with more attention directed at their bodies, coming both from inside and also from the health professionals and the environment in general, together with the changes they experience in their body weight, in their changing silhouette, and limited ability to engage in exercise or other compensatory behaviors to those who use these behaviors for emotion regulation. This means that these expectant mothers may face greater challenges in adjusting to their new role. And pregnancy period is not always pleasant for them. And there is evidence for an association between maternal eating disorders and offspring prenatal and perinatal complications. Pregnant women with eating disorder histories report more psychiatric symptoms during the pregnancy and greater concern about their changing bodies and about the bodies of their kids and the eating habits of their kids. A recent population-based cohort study, for instance, that included over 1 million women found an increased risk for pregnancy complications, preterm birth, and delivering babies with smaller head circumference. But even after the child is born, most mothers report a honeymoon period when they feel good about their bodies and about their child, and they experience diminished symptoms. But after some time, usually between 4 to 6 months, they start reporting greater difficulties. The first issue that is being reported is greater preoccupation with the child's weight, shape, and eating habits. Parents report more mealtime conflicts, that is the recurrent, ongoing, prevalent interactions between a parent and their child are characterized with greater anger and conflicts, and a sense of the mother that she doesn't really know what her child needs and how much to feed them. Parents report shifts from over to underfeeding when they pressure the child to eat more than the child may need, and then also withdraw to underfeeding. While we know there are fluctuations between over and underfeeding, underfeeding is the more prevalent pattern. When we try and think what's going on with the kids themselves, we see, as I said earlier, that infants are born with lower body weight and lower head circumference. This might indicate that their brains have not developed fully during the uterus period. Kids ages between 3 to 9 years old report more vegetarian or health-conscious diet, while vegetarian diet is by no means a negative thing. The issue, I think that these studies may indicate is that children of parents with histories of eating disorders report thinking more about their nutrition and their intake. Children who are 10-year-old whose parents had a history of an eating disorder reported in a study when they were asked and surveyed, they reported greater weight and shape dissatisfaction, more restrictive eating, and more overeating and undereating. So taken together, these findings are a bit worrisome, and we were interested in seeing how we could help these parents. This is why we developed the program that is called Parent-Based Prevention of Eating Disorders. This is a focused intervention for parents with eating disorder histories and their partners. The program concentrates on enhancing parental efficacy and couple communication to reduce the risk of problems in feeding practices and parent-child relationship. I'll review the program in general, and then we'll delve into the more nitty-gritty aspects. The first issue I think to accept is that this is a secondary prevention. It's not a general universal program that all parents in general should participate in. We understand that there is some risk for a child being born to a parent with an eating disorder history, or being raised in a family where one of the parents has significant eating behaviors or psychopathologies, body image issues, weight and shape concerns. But these parents are our partners. They could have been our patients maybe 5 years ago, and now they present again with their child and seeking more support, or this would be really the reason for seeking help for the first time in their lifetime. In any case, we are not judging the parents, and this is by no means an attempt to blame them, because we understand the genetic vulnerabilities, the social pressures, etc., that parents experience, and we work with the parents. This is why this is a parent-based prevention program, to help them to really engineer healthier eating habits and healthy relationships in their families. The program focuses on cognitions and behaviors that are associated with parenting and feeding. So we're not attempting to change parental eating behaviors per se. Although, as I'll show you later, this could be a catalyst for changing parents' behaviors and reducing symptoms, but that is not the target of the program. We focus on their parenting style, the feeding practices, and the communication with their partners. Again, because this program is parent-based, children's attendance is not considered essential. This is not, for instance, family-based treatment. This is a couple-based intervention. We see the children once, and I will outline this momentarily, but we are really focusing on working with both parents. A bit about the history and the involvement of the program. I first started working on this program when I was practicing in Israel in Hadarim Clinic with Einat Zuberi and Esti Mankovsky. I later moved to Stanford University, where I worked with Jim Locke, the head of the Eating Disorders Research Program, who helped me really improve the program and make it more standardized and manualized. Another clinician who's been fundamental to my work has been and still is Kristen Ronfula, PhD, a psychologist who now practices at Stanford. A small note about the program: there is a book that we recently published with Rutledge. The program is empirically supported, and it incorporates strategies that are relevant for parents with past or present eating disorder symptoms. That's something that is important to note. We and also other researchers have found in studies that parental concerns regarding their children and also dilemmas that they may experience regarding feeding are similar when both parents have a current eating disorder or may have past symptoms and are now recovered. So something about the parenting experience, either if they are the mother and they were pregnant, or if they're the father, or they're adoptive parents. In any case, treating your child and feeding them throughout the day, many times a day, many days in a week, many days throughout the month, reignites some of the symptoms. So what are the basics of the program, Parent-Based Prevention? This is a 12-session program that is divided to 3 phases that we'll outline soon. Parents can decide to focus on one child or more. Typically, there is one child with whom parents experience more conflictual relationships regarding eating and feeding. They have more maybe greater concerns about this child's body shape, silhouette, physical activity patterns, etc. Not surprisingly, usually it is the child who is either a girl, if they have kids of both sexes, or the child who has greater appetite and attraction to foods that are high fat, high carb, high sugar, high sodium kinds of foods, and they're more interested in seeing how to regulate this child's eating. As in any focused intervention, especially when it's more behavioral, we really try to facilitate an experimental mindset. We know that parents, when they come, already feel guilty, ashamed, blame themselves, or feel like the environment is blaming them for any difficulties in the child's eating habits or body weight and shape. And in order to help them really cope with these feelings, and also really take the program into consideration, we facilitate experimental mindset. And this is an important aspect, we encourage both parents to participate. So these 12 sessions, most of them, 9 sessions, or 8, I'm sorry, are with both parents. There are 4 sessions in phase 2 where only the parent with the eating disorder history meets the therapist, and they have some time to work through some issues that they might need more support with in compared to their partner. But in general, this is a program that is relevant for both parents, and we really highly encourage both parents to participate. But what do we target? I explained earlier and outlined a few of the issues that may be bothering parents, maybe increasing their stress regarding their parenting, maybe increasing experiences of low self-efficacy. How do you decide what you want to target in this program? We've thought about a few mechanisms that could play a role in the difficulties of parents with eating disorders and their children, but also could serve as the targets of change. And conceptually, the difficulties of parents with eating disorders and their children could be explained using 3 models. The models describe the processes by which the young children of mothers or fathers with eating disorders may be at risk for feeding and eating problems and additional socio-emotional difficulties. And they also account for the parenting-related difficulties that have been documented among these parents. And these processes may have unique, additive, or synergetic effects on the child, the parent, the couple, and the family, as I will now outline. The first mechanism is disrupted division of responsibility in feeding. The parental eating disorder often models the feeding interactions with the child. Excuse me, a parent who has been highly anxious regarding new foods, or eating outside of the house, or eating not according to a pre-designed diet plan, could be highly anxious and feel very ineffective when they need to feed their child in those specific circumstances. Parents with eating disorder histories often report feeling preoccupied with their child's weight, shape, body, and eating. A Lean Sanders model for division of responsibility that I will explain in the next slide really promotes different roles for parents and children in the process of healthy eating. But when we see them at the beginning of treatment, the division of responsibility is often blurred. Parents, as I said, intervene in the healthy regulation of their children out of being worried, and they sometimes overfeed them or underfeed them, and the entire interaction is really colored and tinted with a lot of conflict and disruption. The second mechanism is the comorbidities that compromise parental functioning. Anxiety and mood disorders are two of the most common comorbidities in individuals with eating disorders, as are PTSD, OCD, and personality disorders. These issues affect parental self-efficacy, which is the parents' belief that they could effectively shape their children's behavior. In addition, parents who reduce their eating behavior symptoms after the child's birth often find themselves between a rock and a hard place when the elimination of the emotion regulation strategies through feeding, through their own eating and other adverse behaviors, this may precipitate greater stress. If I'm a new parent and I want to model a healthy eating environment, so I'm avoiding weighing myself or not working out too excessively. And now when I'm a parent, the stress is greater, but I may not have developed sufficient emotion regulation strategies. So these could also play a role in why these parents experience increased stress. The third mechanism is problems in spousal communication over child feeding and daily routines. This is an important point for parents who raise their child with the other parent and not in sole parent families. But in general, we all know that the effective communication between parents is essential because it supports them in their parenting skills. Anyone who's been a parent of a toddler knows that it's good to have a partner with whom you can play offense, defense. But we have found in studies that spousal support can moderate the associations between parental eating disorders and child outcomes only when parental stress is low. When parental stress is high, even a very supportive partner has a very hard time reducing the impact of the parental eating disorder on child outcomes. But in addition, the decreased spousal involvement in the child's daily routines, namely in feeding behaviors, even may potentiate and increase these difficulties. We see a recurrent pattern in many of the families in which the parent with the eating disorder takes greater responsibility for feeding the child due to their concern for the child's eating, shape and weight, etc. But the other parent typically withdraws in order to avoid conflict. These could be couples that are highly functioning in general. They can switch jobs and support one another, purchase houses, take care of an ill grandparent, etc., all with much support and really and terrific communication skills. But as far as the feeding is concerned, the parent with the eating disorder history, we've seen that over and over again in our clinic and in studies, the parent with the eating disorder history experiences greater concern and anxiety and takes control takes over feeding, and the other partner, in order to maintain the positive aspects of the relationship, really withdraws and is not communicating enough with the parent and not supporting them. So this pattern of trying to support your partner by withdrawing, not speaking about feeding practices, ends up not providing them the instrumental and emotional support that they may need. And I will give you some examples as we proceed. So I mentioned the division of responsibility, one of the key concepts that we use in this program. This is a psychoeducation model that derives from Eileen Satter's approach to child feeding. She published the first few papers as early as 1990, and she's still working in this space and contributing to understanding the division of responsibility. According to Satter, things get complicated when parents and children do not maintain their boundaries as far as eating and later physical activity is concerned. According to Satter's model, the division of responsibility, parents should decide what the child eats, where they would eat it, and when they are in charge, that is on the menu, in which room of the house they would eat, and timing of the different meals. But the kids decide whether or not to eat and how much they would eat, and parents cannot intervene with that. And problems in eating habits, according to Satter, occur when parents intervene in what to eat, in how much their kids eat, and if they eat or not. And of course, this model applies to normally developing children and not children with significant feeding problems. I'm happy to later focus in the Q&A period to talk about what happens when you have a child who has existing difficulties. And I may want to later mention feeding versus eating. Feeding, we refer to as generally the process when a parent feeds their child and decides what the child would eat. And eating is a more autonomous behavior that we will see in kids as early as 6 years old and older. Okay, so I mentioned earlier there are 3 phases to the program. And the first phase consists of sessions 1 to 3, and the aim is to mobilize parents to make changes. The focus is on prioritizing personal and relevant goals. This is really where you try and individualize the program, because the concerns of a parent with a binge eating disorder history, who may have a partner who has obesity or have been struggling with weight issues without having an eating disorder, their concerns and dilemmas may be slightly different from a parent, from a couple where the dad had anorexia. So we really want to make sure that we individualize the program to meet what parents need from us. And since this is a very short-term program, it's time limited, 12 sessions only, we begin facilitating behavioral change while still collecting data. Part of the reason that we do that is that parents, especially parents of young children, are typically the busiest group of individuals or of adults that I've met, and also based on my experience. And we really want to provide some value in the program, even before we finish collecting all the data. I'm sorry, I think I jumped. Okay. In the first session, we really focus on collecting data from both parents, interviewing them together, providing some psychoeducation on how the program works, what they should focus on, how in their relationships with their children. We also interview each of the parents alone for 20 minutes in case they would like to discuss some of the issues separately without their partner in the room. The second session focus is a family meal in which the therapist observes the family as he or she invites them to have a picnic meal in the session in the therapist's office. Of course, our offices are prepared for such a family meal. And in contrast to FBT or other treatments that you may have provided, here we do not intervene. We mostly observe the family. This is also an opportunity to have a small chit chat with the child and understand a bit about their temperament. And we observe the family patterns, transactions, and their discussions around food preparation, food serving and eating, the concrete aspects, who brought food, what did they bring, what are they talking about. For instance, one family with whom I worked, in the first 20 minutes of their family meal, they only discussed physical activity that their children engaged in earlier today at school. And the parents weren't aware of that, and it was a good opportunity to discuss these issues, how they bring up physical activity and how do they engage in promoting physical activity in a healthy and not pressuring way, and whether dinner time is the most suitable time to facilitate such discussions. In the third session, we use the data from the family meal to enhance the insights that we already gathered from session one, and we reassess the goals of the intervention. We reinforce the division of responsibility, especially if we've seen any indications earlier in the family meal session. We reinforce this psychoeducation model, we prioritize the targets, and we help the parents plan their first behavioral experiment. So they are asked to choose one thing they would like to focus on and try and work through it throughout the week. In phase two, the focus is really to help parents, especially the parent with the eating disorder history, distinguish their own histories, struggle, current practices and habits, and their parental functioning. So this is what your child needs, 1, 2, 3, and we assess that with the parents when both parents are in the room. And okay, let's see when your eating disorder models your behaviors, maybe it clouds some of your decision making, maybe and there are also many parent-child interactions where the parental eating disorder does not play a role, and that's also important to let the parents know. So not every 2-year-old tantrum is because their dad has a binge eating disorder. Okay, and not every adolescent who is struggling at school or with her friends, that's because her mother is also preoccupied with her own weight. So it's also important to reinforce the healthy behaviors and the healthy parent-child relationship, and again, reduce self-blame and guilt. So most sessions are with the target parent, a parent with the eating disorder histories, and we review behavioral experiment and test some modifications. In phase 3, both parents return to for meetings. Mostly what we saw in phase 1 and 2, almost all parents want to focus on family dinner. Since dinner time is highly conflictual and parents feel like they're struggling, mostly at dinner, we as parents are also tired. Maybe we haven't had a chance to eat well earlier, and with the child's being tired as well, and eating disorder history or the current eating habits, this is all the perfect storm for highly conflict interactions. But by session 9, we see with with all families or most families that these issues have diminished, and now this is a time to really utilize the intervention and focus on the 2 other mechanisms, the comorbidities and maybe spousal communication. So we assess the parents' movement towards the desired change in their feeding practices and their child's behavior. We support parents in planning behavioral experiments in broader risk aspects of parental and child functioning. So this might be a good opportunity to discuss, review, and maybe try and target the tantrums that I mentioned earlier, or the adolescent struggles at school, academically or socially, etc. We really utilize these sessions. In most families, we see that there is really reduced conflict around eating, and parents are more free and more open to discuss other issues. When I think one of the issues that I do want to mention are the barriers for parental participation. Parent-based prevention is a wonderful program. It's really a pleasure to deliver it because you can see very quick impact on families when you utilize the strategies, and I will soon show you data on how effective it is, but I do want to mention the barriers, which if you would implement a program or work with parents with eating disorders, you may experience in your own clinics. First, for parents, organizational difficulties are an issue. So many of them do not or find it hard to believe in the division of responsibility approach, the fact that you should take a step back and not comment on how much your child eats. If you provide food that you perceive as healthy. Some current patterns are perceived as too much ingrained for some of the parents, and they may not want to talk about these issues. Some parents perceive their parental self-efficacy as poor. And this is one of the reasons that we incorporate the involvement of both parents, and for single parents, another support person, or we utilize their support system in order to help them continue making the changes even when they feel that they are not doing this effectively. There could be some challenges in spousal communication that parents are worried about discussing about. And some parents also do not want to associate themselves anymore with the eating disorder. They feel like it's something that happened in their history and is not affecting their parental functioning at the moment. And of course, we fully respect that. One solution that we found to support parents remotely is providing the intervention online. So we designed a shorter, more focused version of parent-based prevention for parents following bariatric weight loss surgery. And I wouldn't say that we did it just because of the acronym, but it's PBPB, Parent-Based Prevention for Bariatrics. So I thought that was kind of funny. But we provided it online. We asked parents, instead of coming to the clinic to have their family meal, to video record the family meal and to send us it through a secured HIPAA-compliant server. And that worked very, very well. We were able to treat at Stanford people from all around the US and Canada, and the study is now has been accepted to publication in a family process journal. I'd like to, in the few minutes that I have, to run really quickly through the feasibility study that we've done. Parent-based prevention was studied both in a pilot study and then in a randomized controlled trial that was supported by Stanford University Maternal and Child Health Research Institute and by the Hilda and Preston Davis Foundation. We invited parents with any lifetime eating disorder diagnosis to participate in the program and randomized them to either receiving the treatment immediately or following a 16-week waitlist period. We restricted this only to families who had at least one child between 1 to 5 years of age. We focused on retention rates because this was a feasibility study, and also changes in the child feeding questionnaire, subscales of concern for the child's eating, monitoring and restriction, as well as parental eating psychopathology. Although we published this heavily in using online materials and social outlets and social media, we were able to recruit only women with eating disorder histories. Unfortunately, no men reached out about the study, which wasn't the case, by the way, with the bariatric history group, where the distribution was more or less equal. In our study, diagnoses were distributed quite randomly between 40% anorexia nervosa, 30% bulimia nervosa, and 26% binge eating disorder. And most families had 2 children. We screened 31 mothers and 24 consented to participate. Most mothers said that the problem for engaging in the program is logistic or speaking with their partner about the intervention, so they hope to receive it alone. I think that that's a valid issue. The only problem is that this was a research study, so we weren't able to recruit mothers without their partner's presence. And just to run real quickly through the results of the study, you see in the turquoise bars the parents who received the parent-based prevention program, and in the light purple, parents who were on the waitlist program condition. Parents who received the program reported they had reduced concern for their child's shape and weight, lower monitoring, lower restrictive behaviors, but also reduced pressure on the child to eat. If you remember from one of my early slides, the parents report fluctuations in the pattern between moving from overfeeding to underfeeding. Therefore, we were happy that we were able to help parents reduce the pressuring behaviors and not only the restrictive behaviors. Okay, so my presentation comes to its end. I'd like to end with a few conclusion remarks. We first see that parents with histories of eating disorders are well-intentioned, interested in receiving support, and they can change over time. There are some overarching difficulties that are common to many parents with eating disorder histories, but parent-based prevention is a feasible treatment for this group. We know that attrition could be a problem, and enrollment in these studies in general. It is our duty to continue finding some new methods to work with parents. And of course, future studies and future funding is always needed to help really advance these programs and make them more adapted and more effective for the parents. But I hope that what I began with today, saying that I feel optimistic about how we can understand and support parents with an eating disorder history, both mothers and fathers. I hope that you all share now my optimism. Thank you so much for spending this hour with us today. Let's open this for questions and answers.
Wow, thank you so much, Shiri, for that wonderful presentation. I have to say, I feel very grateful that we have a program like this that would hopefully reduce the shame and stigma around getting support for some of these challenges. I think it's very clear that parenting children in general is challenging, and there's a lot of ideas about how to get feeding and eating right. And so I'm super happy that you've created this intervention and that we have such positive results. It's very encouraging. We do have some questions already, some wonderful questions, and others are welcome to type questions into the Q&A box. I'll go ahead and start reading some of them off. One of the questions is really about what to do or what you've done in the past when a parent comes in is really kind of unaware of their eating disorder symptoms or perhaps the impact of their symptoms on their child. I think one of the questions that comes up around that is how do the families get to you in the first place?
Okay, that's a really, I think that's a really important topic. In parent-based prevention, we were lucky because the parents who arrive are motivated and they acknowledge some of the issues that they experience. I think it's more challenging for clinicians. When you see a parent or an adult in general, that come in and seek treatment for other reasons, and then you see or you are concerned about some issues with their parenting, or maybe that an eating disorder histories might affect them. I think that like with any other issue relevant to treatment, once there is a strong therapeutic alliance, it would be easier for the therapist to bring up this issue as they would with any other topics they would like to discuss. When you use your clinical skills and ask questions in the appropriate tone, tact, and timing, these issues could be addressed. One thing that I would want to mention is that there are many issues that we know with adults with eating disorders. For instance, that both males and females with a history of an eating disorder report greater intimate partner violence than controls, for instance, in studies. So this is also something that you would like to interview your client about if you think that's of relevance. So again, really has a lot to do with the therapeutic alliance.
Thank you. I guess I'm wondering how aware you've found the patients coming to the program to be of their eating disorder on average, if you could comment on that.
Again, with parent-based prevention, we've been pampered with people reaching out because they think there's an issue or they experience an issue with their partner and they would like some help in supporting their partner more. But of course, I think that every parent has some, difficulty acknowledging all the things that we transfer to our children, or some issues that we dislike about ourselves or about our partner, and we see them in our children. That's hard. Even, I can say that as a parent in general, it doesn't have to do a lot with only an eating disorder history. So I think they mostly understand that the internalization of the thinnest ideal is a problem, but also these patterns are for many individuals very much ingrained, and also we live in a in a society whose perception of body image and healthy eating habits could be often distorted. Therefore, these are two competing forces that parents need to find their own narrative within that framework.
Thank you so much. Another question that we have is related to the partner's experience in treatment. So this is kind of a two-part question. So what is the experience with fathers or step-parents' participation in the program? What has kind of been your experience with their participation? And have you had to use any different approaches to motivate their participation?
Okay, that's also an important topic. As I said, I feel that spousal and partner participation is super important because parents need the instrumental and emotional support. We've had families where the other parent, it was mostly a dad in the study, were not involved in dinner time, arrived later, or just were in their study during that time, and they understood that it's better for their wife's mental health and for their child's if they got out and become more involved. And I think that it's the involvement is super important, and this is what we talk about with parents. But I have to say, honestly, that sometimes mothers call me and ask me, okay, so what should I tell my husband? And I tell them all the right things, but then I add, but you know what, he's your husband, not mine. So you know what you need to say in order to make them do something that they dislike. It's probably not the first request that you asked and he or she were not willing to do. So, so I think it has a lot to do with the couple's communication.
Yeah, absolutely. Have you found any differences in outcome depending on whether or not partners participate?
In these specific randomized controlled trials, we asked parents to participate with their partners. We enrolled, if it were a single parents, we enrolled them, but when it was a dual parent family, we asked both parents to participate. So we haven't had a chance to collect data on how a parent would cope and the effectiveness of the program if only one parent would participate. I would assume that, in real life, not in a randomized controlled trial in a university setting, having only one parent participate would not be so uncommon. And personally, I would prefer delivering that intervention to one parent than none.
Okay, one other question that we have is about the age of the child. So in the study, why was it necessary for one child in the family to be aged under 5 years?
I think that for the purposes of that specific study, we wanted to focus on a time, on an age range when feeding plays a role. This is a new treatment that we were testing out. We didn't want to start with adolescents because there are so many other functions and influences that could impact the relationship and the feeding environment. We're still looking into studying this intervention in older children, but this would, bring out greater involvement of the children more than in this specific model. I don't see a parent of like a 14-year-old engaging in really significant changes in family lifestyle without involving the child, but that on the other hand would also bring an opportunity to ask more questions and maybe some greater conflict and open discussion. It could go to different places. We haven't tested that yet.
Certainly, and it makes sense that you're targeting young kids, given this is a prevention model. And unfortunately, we may end up seeing some of the teenagers in our clinic when they are struggling with an eating disorder themselves, and find out in that context that another parent or their parent is struggling. So we have time for, I think, one more question. Looks like we're getting a couple here. Oh, no, thank you. We'll give it one more minute. Does anyone else have any other questions for Dr. Sharvit? And if not, Shiri, do you have any other comments you'd like to share? Any last words of wisdom you'd like to share with the group?
I think one issue that I haven't mentioned is that although parental psychopathology and other comorbidities are not the target of the intervention, we have seen throughout our studies that both parents receiving parent-based prevention report reduction in eating psychopathology and comorbid symptoms, lower parental stress, and improved communication with their partner, even again when these are not directly targeted in the program. So that's one thing that I wanted to mention also.
Wonderful. Well, thank you so much again. That wraps it up for us today. It was a wonderful presentation. And as a reminder, everyone can find out more about this and other upcoming webinars by visiting aedweb.org and clicking on the events tab. Thank you again so much for participating. Hope you all have a wonderful day.
Thank you, everyone.